You know, that feeling. Just dragging yourself through the day, like
Yeah.
your battery's constantly on low no matter how much sleep you get.
Yeah, that persistent draining tiredness, it's something so many people experience.
Well, today we're digging into something that could be behind that feeling. Microcytic anemia.
Mm-hmm.
Basically, it means your red blood cells, the little guys carrying oxygen everywhere, are smaller than they're supposed to be.
Exactly. And it's not just a minor size thing. These smaller cells often point towards a problem with how your body's making hemoglobin.
That's the oxygen carrying part.
Right, the crucial part. Or it could be an issue with how the body's handling iron, which is, a key building block for that hemoglobin.
So our mission for this deep dive is to really help you get to grips with microcytic anemia.
Mm-hmm.
We're going to cover what it is, what causes it, who's more likely to get it, and how it's managed.
Think of it as your focused guide. We're pulling together the key info you need to understand this condition properly, covering everything from the basics right through to potential complications. We want this to be genuinely useful for you.
Okay, let's start right at the definition then. Microcytic anemia. Smaller than normal red blood cells in your bloodstream. Simple as that, really.
It is, but the implication is that something's up with production. As I said, it usually boils down to a problem making hemoglobin or an issue with iron metabolism.
Right, like if you don't have the right ingredients or the right instructions.
Precisely. Think of hemoglobin like a complex structure. If you're short on a key component like iron, or if the genetic blueprint for building it is faulty, you end up with these smaller, less effective red blood cells.
Got it. Maybe a little memory tip here. Think micro for small cells. And these small cells often point to issues with iron or the building blocks for carrying oxygen.
Good one. So let's talk causes, the etiology. Why does this happen? Well, the number one cause, the most common reason by far, is iron deficiency. Ah, okay, so not getting enough iron.
Yeah, either not enough in the diet or losing iron through blood loss. Think heavy periods or bleeding in the gut, or sometimes the body just isn't absorbing iron properly from food.
Right, iron deficiency is definitely the headliner. But there are other important causes too, aren't there?
Absolutely. Things like chronic diseases.
Such as?
Chronic kidney disease is a big one, or inflammatory conditions like inflammatory bowel disease. These long-term illnesses can interfere with red blood cell production or iron use.
Okay.
Then you have genetic disorders that affect hemoglobin synthesis itself. Thalassaemia is a really key example here.
Thalassaemia, right, that's inherited, isn't it?
Yes, it's a genetic condition where the body doesn't make enough of certain parts of the hemoglobin molecule. Lead poisoning is another cause, though less common now in many places.
And any others?
Less common ones.
Yes, things like congenital sideroblastic anemia, another inherited issue. And sometimes anemia of chronic disease can present with microcytic cells, although it's often normocytic, meaning normal-sized cells.
Now, there was a really important point in the information we looked at about older patients.
Ah, yes. Very important. If microcytic anemia develops seemingly out of the blue in an older person, it really warrants prompt investigation.
Why is that?
Because it could, unfortunately, be a sign of an underlying malignancy, like bowel cancer causing chronic blood loss. So it needs checking out urgently.
That's crucial to know. It sort of leads to that question someone listening might have. I feel tired all the time. Could it be this? When should I actually worry and see someone?
Exactly. And the answer is, if you have persistent, unexplained fatigue, especially alongside other symptoms we'll talk about, definitely go and speak to your doctor or healthcare provider. Don't just dismiss it.
Okay, good advice. So who is actually more likely to develop microcytic anemia? What are the risk factors?
Well, building on the causes, inadequate dietary iron is a major one. This affects certain groups more, like vegetarians or vegans if they're not careful, or people with poor diets generally.
Makes sense. And blood loss.
Yep, chronic blood loss is key. So women with heavy menstruation are at higher risk. Also, anyone with conditions causing gastrointestinal bleeding, like ulcers, or as we mentioned, sometimes cancers.
And the chronic diseases again.
Yes, definitely. Chronic kidney disease, inflammatory conditions like rheumatoid arthritis or IBD. Also, genetic factors having a family history of something like thalassaemia increases your risk significantly.
Any external factors?
Exposure to lead, as we mentioned, is a risk factor, and certain medications, including some chemotherapy agents, can also sometimes lead to it.
So a quick way to frame those risk factors. Think about ways you might lose iron or not get enough, plus those inherited conditions and maybe some external triggers like toxins or meds.
Nicely put. Now, pathophysiology, how does this actually happen at a biological level?
Right, the how.
It comes down to that impaired hemoglobin synthesis or disrupted iron metabolism. For whatever reason, lack of iron, genetic defect, chronic inflammation interfering the bone marrow just can't produce enough normal hemoglobin.
So it compensates.
In a way, it leads to the production of red blood cells that are smaller than usual and often fewer in number too. With iron deficiency specifically, you just don't have enough iron stores.
The raw material.
Exactly. Not enough raw material to build the normal amount of hemoglobin for each cell, so the cells end up smaller, kind of rationing the iron they do have.
It's like that factory analogy, not enough key parts, so you make smaller products and fewer of them.
That's a great way to picture it.
Okay, so if someone's feeling tired, maybe has some risk factors, we know microcytic anemia is a possibility, but it's not the only possibility, right? Let's talk differential diagnosis.
Absolutely crucial. Fatigue is so non-specific. So yes, other types of anemia need to be considered. Vitamin B12 and folate deficiency anemia are important ones.
But they cause large cells, don't they, macrocytic?
Generally, yes. That's a key difference we look for in the blood count cell size.
Yeah.
But the symptoms like fatigue can overlap. Then there are other hemoglobinopathies like sickle cell disease. We also need to keep anemia of chronic disease on the list, as it can sometimes be microcytic, and lead poisoning too, and then those rarer inherited disorders like congenital sideroblastic anemia.
So lots of potential causes for similar feelings. The blood tests are really key to narrowing it down then.
Essential. That full blood count, looking specifically at the MCV, the mean corpuscular volume, or average cell size, is usually the first big clue telling us which direction to look in.
Right. Let's zoom out a bit. How common is microcytic anemia? What's the epidemiology look like?
Well, because iron deficiency is the world's most common nutritional deficiency, microcytic anemia driven by iron deficiency is pretty common globally.
And here in the UK.
Our info suggests prevalence is around 3 to 5% of the population, which is quite significant.
And the other causes, like thalassaemia.
Much less common overall in the general population. However, thalassaemia prevalence is much, much higher in specific ethnic groups. People with Mediterranean, Middle Eastern, South Asian, or Southeast Asian ancestry, for instance.
That's really interesting. It shows how ancestry and genetics can really influence risk profiles for certain conditions.
It absolutely does. It's why taking a good family history and considering ethnicity is so important in medicine, particularly when investigating anemia.
Okay, let's get practical. What might someone actually feel or notice if they have microcytic anemia? The signs and symptoms, the clinical presentation.
The absolute classic symptom is fatigue, just feeling wiped out, lacking energy. Weakness is common too.
Anything visible?
Yes, pale skin or pallor, particularly noticeable in the nail beds or the lining of the eyes, shortness of breath, especially on exertion, dizziness or lightheadedness, headaches.
What about that cold feeling?
Yes. Cold hands and feet are frequently reported. The body's trying to conserve oxygen for vital organs.
And if it gets more severe?
Then symptoms can escalate. You might get chest pain, especially if there's underlying heart disease, a rapid heartbeat or palpitations as the heart works harder, and even difficulty concentrating, sort of a brain fog.
It's worth saying again, isn't it? Lots of these are common feelings. Tiredness, headaches.
Definitely. But it's the persistence, the severity, or having a combination of these symptoms that should prompt you to think, okay, maybe I should get this checked out.
Right. So if someone does go to the doctor with these concerns, what investigations can they expect? What are the key tests?
The starting point is almost always a full blood count, the FBC.
We mentioned that one.
Yep. It's a standard blood test. Looks at red cells, white cells, platelets, and crucially, it gives us the mean corpuscular volume, the MCV. In microcytic anemia, that MCV value will be low, below the normal range.
Okay, so low MCV points towards microcytic. What next?
Often the lab will then do a peripheral blood smear. They take a drop of blood, smear it on a slide, stain it, and look at it under a microscope.
What are they looking for?
The size and shape of the red blood cells. In microcytic anemia, they'll see small cells, often pale ones too. That's called hypochromia. This visual check can give clues about the cause.
Makes sense. After the smear.
Then typically come the serum iron studies. These are more specific blood tests measuring iron levels.
What do they measure exactly?
Usually serum iron itself, ferritin, which is a measure of the body's total iron stores, really important, and transferrin saturation, which tells us how much iron is being transported around.
So FBC for cell size, smear for visual, iron studies for the iron levels. Does that usually nail the diagnosis?
For iron deficiency, those tests are often enough. But if those results are normal, or if something like thalassaemia is suspected based on the FBC, smear, and maybe family history.
then you need more tests.
Exactly. Further tests might be needed to find the underlying cause. Hemoglobin electrophoresis is a key one if thalassaemia or another hemoglobinopathy is suspected. It separates out the different types of hemoglobin.
Okay.
And in some situations, particularly for rarer inherited conditions, genetic testing might be required for a definitive diagnosis.
Right. So, memory tip for investigations.
Mhm.
Start with the basic count, FBCMCV, then look closer at the cells, smear. Check the iron levels specifically, iron studies, and then, if needed, move to more specialized tests like electrophoresis or genetics.
That covers the main pathway, yes. So once you have the diagnosis and hopefully the cause, what about management? How is microcytic anemia treated?
Well, as you'd expect now, it really hinges on the underlying cause. Our info is clear. Treatment has to be tailored.
Makes sense.
So for the most common cause, iron deficiency anemia, the main treatment is iron supplementation, usually tablets.
To build the stores back up.
Exactly. But, crucially, you also need to find out why the person was iron deficient and address that. Is it diet? Fix the diet. Is it blood loss? Find and stop the bleeding. Is it poor absorption? Investigate why. Just giving iron might not be enough long-term if the root cause isn't sorted.
Very true. What about the other causes? Thalassaemia, for example.
Yeah, totally different approach. For severe thalassaemia, management might involve regular blood transfusions to provide healthy red blood cells. Sometimes medication to help remove excess iron from the body because transfusions can lead to iron overload. And genetic counseling is really important for families affected by inherited conditions like thalassaemia.
And for anemia related to chronic disease.
The focus there is mainly on managing the underlying condition, like the kidney disease or the inflammatory disorder. You can control that better, the anemia often improves.
So definitely not one size fits all. Finding that root cause is absolutely key.
Couldn't agree more. What about the prognosis then? What's the outlook generally like for someone diagnosed with this?
Again, it really varies depending on the cause and how well it's managed.
But for the common iron deficiency type?
The good news is, for most cases of iron deficiency anemia, if it's diagnosed and treated properly, iron supplements, addressing the cause, the prognosis is generally very good. Symptoms improve, blood counts return to normal.
That's reassuring.
It is. However, for chronic conditions like thalassaemia, it's more about long-term management. And it's important to remember that chronic, severe, or untreated microcytic anemia, whatever the cause, can lead to complications.
Right. That brings us nicely to complications. What are the potential problems if microcytic anemia isn't dealt with effectively or if it's particularly severe?
Well, because the blood isn't carrying oxygen as efficiently, the heart has to work harder to compensate. Over time, this strain can lead to heart problems, like an enlarged heart or even heart failure in severe, prolonged cases.
Wow, okay. Anything else?
Yes, it can impair immune function, making you more susceptible to infections. In children, chronic anemia can unfortunately affect growth and development, both physically and mentally.
And specific complications related to the cause.
Exactly. For instance, with thalassaemia requiring frequent transfusions, iron overload can damage organs like the liver and heart if not managed with chelation therapy, which removes excess iron.
So it really underscores the importance of getting diagnosed, getting the right treatment, and sticking with follow-up and monitoring.
Absolutely. Regular monitoring and appropriate management are crucial to prevent these potential long-term issues and maintain the best possible health.
Okay, let's try and wrap up this deep dive on microcytic anemia. The main takeaway. Small red blood cells, often linked to iron problems, but there's a range of possible causes that need proper investigation. Getting the right diagnosis leads to the right treatment.
Well summarized. And maybe a final thought for everyone listening. Pay attention to your body, especially your energy levels, and any persistent symptoms like the ones we've discussed. Don't just brush them off.
Yeah, good point.
And maybe ask yourself, what simple steps could you take to ensure you're getting enough iron in your diet? Or if you know there's a history of blood disorders in your family, perhaps that's something worth mentioning to your doctor next time you see them.
Really useful prompts. Thanks for joining us on this deep dive. If you're revising or just want to learn more in a structured way, do check out PassTheMSRA.com and FreeMSRA.com for more resources.
Great resources.
Until next time, take care of yourselves.